First, I'd like to thank the Queensland Government and Health Workforce Australia and Queensland Health for this wonderful opportunity. To be able to do the type of research that we've been able to do often doesn't come about without a considerable amount of effort and input from state and federal governments, and not to mention local governments as well. And listening today with the presentations, there is such a plethora of rich information that is already there. Before I start, I'd just like to say one thing. We heard this morning about silos. We heard about the in-between. We heard about collaboration. I think what I've also heard today is that there's been a lot of collaboration within people's regions. I think there is a lot of opportunity for collaboration across these projects as moving forward, as an innovative way to move forward in that direction. First, I'd like to thank our research team, our wonderful people that we have up there. We have Professor Margaret McAllister, we have Professor Brenda Happel, we have Associate Professor Monica Moran, not to mention our wonderful colleagues that have been part of that team, and also the research team that has been instrumental in helping us bring this whole endeavour to fruition. So what are the objectives for this exercise that we talked about? One was to identify and consult with key stakeholders around that whole notion of qualitative information concerning what are some of the innovations, some of the barriers, what are some of the facilitators to developing a sustainable capacity, clinical placement, ongoing workforce. Explore current patterns of mental health workforce integration. What are they? Facilitate regional networks and ongoing collaborative partnerships to build capacity for mental health workforce integration. Provide training to work integrated learning facilitators to recovery methods, and consult with them regarding their training provision. I will talk first about the capacity building. I will then hand over to Louise to talk about the recovery initiatives of this project, and then I'll conclude after that. So first we had to think about developing and evaluating what is out there in terms of clinical placements in traditional and non-traditional areas of healthcare delivery. And when we talk about traditional, we're talking about what we currently use in the main. When we talk about non-traditional, we're talking about alternatives. What type of alternative opportunities are there within our communities that could assist us in not only enriching our students' experiences, but providing them with the needed opportunity to have that clinical exposure. A difficult task. We also wanted to develop a series of innovative workshops around that whole notion of recovery as a framework for clinical education. We are in that real transition of moving from a pathologised approach to healthcare delivery to moving towards a more health strengths model approach to healthcare delivery. How do we make that transition? And the way we make that transition is by educating those key stakeholders who are the gatekeepers of knowledge for our students, and working with people within the clinical facilities to ensure that they take on that mantle and move forward as well, that it's not just left at the gate. We also wanted to develop a repository of information about what exists out there. What was quite fascinating, we thought we knew it all. We thought we knew where clinical placements were available, what they looked like, what the quality of them were, etc. And what we found out was that there are so many underutilised clinical facilities out there that we did not even know existed, and that people were aching to be involved but had never been invited. And so that was a rich experience to think in terms of where can we go and what can we do, and how can we put aside what we perceive as the current barriers to clinical access and look at innovative alternative ways. The regions that we looked at were the Sunshine Coast, Wide Bay, Central West and Mackay. A very, very large region to go out and collect data from. The different disciplines we looked at were nursing, occupational therapy, social work and psychology, because the mandate was not only around finding clinical placements or exploring alternatives, it was about how we could look at what is happening across the healthcare sector and see what patterns of delivery and access to clinical placements are available. We first began by developing a survey. We said that if we want to gather significant information through face-to-face breakfasts, etc., which were absolutely fabulous, we needed to go out and get some idea about what were the needs of our health industry. So we put together a survey, we did a pilot study around that. We then made it accessible through SurveyMonkey, and the information that we received back became the structure for developing not only the breakfast, which was around capacity building, but also the recovery workshops, so that we were able to target key elements or key needs of the people that we were going to be working with. The workshops, the breakfasts were conducted in each of the areas, the Sunshine Coast, Wide Bay, up towards Bundaberg, Rockhampton and Mackay. And what was interesting with those breakfasts is that the type of needs were quite different. Initially we were thinking about, let's develop a model that we can look at that integration, that connection, that synergy between industry, healthcare providers, educational providers, etc. And what we found that there were unique paradigms existing within each of those facilities, which then brings it back to the development of different models, ultimately. We then looked at the actual workshops, and in the workshops we constructed a workbook that the people would use. We also developed some DVDs, which were made by members of the project team, so that they became important key points of the approach to recovery. The analysis of that has taken place of both the workshops and the breakfast, and it's been extremely positive. We also conducted interviews just recently with a number of people who attended both the workshops and the breakfast, and they're in the process of being analysed. Okay, so what were some of the questions that we asked in terms of the survey? Do you offer clinical supervision? 57.7% said yes, 42.3% said no. Quite an interesting figure. When we looked around and thought we are at saturation point, how come 57% said yes and 42% said no? Lots of space. Student placement models: block, integrated and ad hoc. It's interesting that people hadn't explored other models in terms of availability, etc. Preferred model of clinical placement: facilitation, should say preceptor and other. So facilitator and preceptor certainly came to the fore. Preparedness to explore alternative placement options: 80% said yes, 20% said no. What does that tell us? That industry is ready to cooperate and collaborate with us in all our endeavours to facilitate student learning. Are we making the most of that type of situation? Preparedness to build capacity for alternative clinical placements: an interesting question. 84% said yes. Only 16% said no. And as we went round and spoke with different people outside the traditional framework that we currently locate our students, the energy that was there about how can we think outside the square to accommodate you. One of the issues was that they didn't want to talk about barriers. They said the barriers are there, and if we start talking about barriers at the first instant, we never get past it. So let's think more creatively and then look at the challenges that that may bring in terms of realising that potential. Collaboration with other providers in building capacity. 88% want to collaborate. And yet, what do we see? We still see ourselves as living in silos. Just recently on the Sunshine Coast, on a number of different panels there, and had to introduce members of Queensland Health and Quill and so forth to each other because they were running parallel programs. They had heard of these other programs, they had heard of the key people involved in them, but they had never met them. And now they're collaborating extraordinarily well. And so the richness of that information sharing has led to a very collaborative nexus on the Sunshine Coast. Support for development of a regional framework. 88% said yes. They yearn for that regional framework to take control of their own destiny around building capacity and enhancing student learning and growing their own. An important consideration for the future. Involvement in the development of a regional framework. 76% said yes. So the question that we may have to start asking ourselves is why not? Why isn't this being realised? Where are we going wrong? What turns have we made that haven't really achieved the outcomes that we set off to achieve? The momentum, the commitment, the motivation is there for the asking. It's all around now the process by which that's achieved. Perceived barriers that restrict availability of clinical placements. 74% said, yes, there are a lot of barriers. But there was the however. And the however was, don't let us go down that path of barriers because that stifles our creativity and our initiative for moving forward. We know the barriers. We've been burnt by the barriers. We don't want to give the barriers that extra fuel for continuing. Let's see how we can move around those barriers when and if they emerge. Confidence to provide interprofessional student placements. 73% said yes. Once again, 26% said no. The same message is coming through. Confidence in using mental health recovery principles. Louise will speak to that, but I will say one thing about this, is that in our data, people believe that they are practicing from a recovery framework. When asked, they really aren't. The number of models of recovery frameworks out there are consistent with the number of nurses who consider themselves to be practicing from that model. And none of them appear to bring it back to the consumer's focus of the recovery movement. Recovery has been defined by clinicians, not by consumers. And so each of us, in each of our disciplines, from the data suggests that we believe we are there, but we are not. Okay, in terms of supporting students in the use of recovery, 75% said yes. They want to use that, but in essence, they haven't got that skill, the capacity, that know-how, not only to change their own philosophical base, but also to work with students and changing the culture of nursing in mental health. Once again, a series of forums were conducted in terms of lived experience around recovery, and they were in Rockhampton, Mackay, Bundaberg and on the Sunshine Coast. I'd like to now hand over to Louise.
I think I have like 10 seconds, so I'm going to keep this as
we're doing very well.
short as I can.
We're the last one.
Okay, so I'm a lived experience lecturer, lived experience in mental health. Probably most of you haven't heard of that before. Mine's the first known full-time position of its kind in the world, in much the same way that my Indigenous colleagues can represent Indigenous culture. I represent a very specific set of experiences, a culture in a way, a culture of oppression. Of a very unique experience of losing personhood, of losing a sense of belonging and citizenship, of mental health service use, of mental health issues, of the stigma that is both external and internalised when you have those experiences, and of recovery, which is really important as well. The lived experience movement is starting to build, and something which I think is a bit funny, most people have heard of recovery now because it's been mandated for a few decades and it's so clearly in every policy you can throw a stick at. But a lot of people don't realise that recovery was the result of a couple of centuries of people like me who had recovered against the odds, against the prognosis of the time, which believed that recovery was not possible for people with mental health issues, that it was in fact a deteriorating condition, who just continued to basically write about and publish their accounts of having recovered. At the time it was called spontaneous recovery, but over time the voice got louder, and then some friends of lived experience, friends of recovery, also took it up and did some research and started to quantify it a little bit. So basically, recovery concepts come from the lived experience movement. To a very large degree, it's been taken away from us, it's been co-opted, and as Tony described, people who really don't understand these experiences or what it means are trying to educate other people who don't understand these experiences or what it means. So CQU University's made a really bold stance by, I think, setting the bar very high and deciding that all recovery education that comes out of the university will be led by someone with a lived experience, hence my position was developed. So the work that we did in terms of the workshops was lived experience led, as will everything to do with recovery at CQ University. So I think that was kind of something about our project that was a bit different and a little bit important. So the workshops, very quickly, contemporary recovery principles, lived experience principles, very sort of hands-on, very interactive stuff. We did some videos. One of our big focuses was on recovery myth-busting, because I think that's the first thing that we have to do. This is not, this is what you think you know, but really just these are some ideas about recovery, and this is where we're really coming from. Because I guess the main message that we're kind of trying to get across is clinicians have a lot of confusion about recovery, but consumers and lived experience workers have no confusion whatsoever. We know exactly what recovery is. So if you want to learn about recovery, come talk to us about that. So yeah, that's the workshops, and back to Tony.
Thank you. So can I just whiz through?
We do need to have time for some questions.
Yeah, sure. In terms of evaluation, I'll just, we may want to just have a quick look at those. We want to first, traditional providers of work integrated experience for students is nearing saturation point. We know that. Non-traditional is not being used as it could be. The capacity is huge. Both traditional and non-traditional providers are eager to collaborate in building capacity. Fantastic. Willingness on the part of both sexes to work together on local or regional frameworks for work integrated learning exists. Recovery workshops and education are highly needed. There is a hunger for such a path to education that informs innovative change to exist. Rural and remote areas continue to be disadvantaged in both part of an inclusive collaborative framework and in the provision of education around recovery. What we hope to do from here on in is to explore some of these evaluations and see how they can take us forward in terms of a sustainable model within our various regions, and in the development of an educational framework around recovery that could be tried and tested and rolled out as a national initiative.
Thank you, Louise and Anthony.